Hey everyone, welcome back to Coursetta Nursing. My name is Will Kirkpatrick. I'm a nursing educator inside the Coursetta Nursing membership, and today we're going to go over Addison's disease versus Cushing's syndrome. So overall, we're going to be comparing the pathophysiology, the signs and symptoms, causes, risk factors, and of course the complications, along with nursing management and diagnostics. So if you want to compare these two conditions because they are polar opposites, let's get right into it. And if you are a note taker, please remember that we have a free pathophysiology concept map on our website, CoursettaNursing.com. So make sure to download that and take notes along with this course. All right, so let's get right into it. Addison's disease versus Cushing's syndrome. We're first going to start talking about Addison's disease and then compare it to Cushing's syndrome throughout all these concepts such as pathophysiology, the signs and symptoms, and so on and so forth. If you have watched one of our videos before, you know that we dive very deeply into the pathophysiology. So Addison's disease, what is going on with Addison's disease? To explain it very simply, Addison's disease is a decrease of cortisol and aldosterone. And because of that, we have dehydration and inflammation. And the symptoms that typically arise from that is hypoglycemia, hypotension, and then lastly, androgen insufficiency. So we're going to explain all these in great detail, but that's a quick summary of what Addison's disease is. So let's get into how this happens with the pathophysiology. So it's important to note that we have three different pathways of pathophysiology when related to Addison's disease. It is primary, secondary, and tertiary. So when we talk about primary Addison's disease, it is a disease affecting the adrenal glands on top of our kidneys. As we talked about, it's a decreased level of cortisol release and aldosterone, which causes dehydration and inflammation. So when we're talking about primary, it's a direct attack, typically autoimmune, on the adrenal glands themselves. And that causes the pathway that we just talked about. What if you have a question that says secondary Addison's disease? Secondary Addison's disease is talking about the pituitary gland. So on the pituitary gland, if you may or may not have went over on your endocrine class, is that there is an anterior and posterior pituitary gland. So one of those hormones coming from that anterior lobe is the adrenocorticotropic hormone. In short, it's ACTH. So make sure you guys write that down. When the pituitary is not releasing enough of that, it's not telling those adrenal glands to release that cortisol or the aldosterone. So think of it that the adrenal glands don't just make it themselves or make the decision themselves. They rely on that pituitary gland to let them know that they need more cortisol or aldosterone. So when that's not happening, that's where we have secondary Addison's disease, where if it's directly attacked on the actual adrenal glands themselves, then it's primary. Now what about tertiary? Tertiary is talking about the hypothalamus. So the hypothalamus has to communicate to the pituitary gland to make more ACTH. So the hypothalamus has a hormone called corticotrophin releasing hormone. In short, it's CRH. So that gets released to let the pituitary gland know to release the ACTH that we talked about, to then let know the adrenal glands to release cortisol and aldosterone. Well, specifically with the tertiary, we have a cortisol lowered issue only because it's the CRH that needs to be stimulated. So the aldosterone can still be triggered, but the cortisol in this case is not triggered because of the hypothalamus not communicating that we need cortisol in the body. So think of it like this. Primary, of course, what is the main gland that we're talking about here? We're talking about the adrenal glands on top of those kidneys. So if there's a direct attack on that and they're not able to release the cortisol and the aldosterone, then that's called primary. That's the primary attack. Well, secondarily, we rely on what? The pituitary gland, because the pituitary gland releases ACTH to then let know the adrenal glands that they need cortisol and aldosterone. Well, then the secondary, that pituitary gland can still tell the adrenal glands that they need aldosterone, but if we have a tertiary issue where the hypothalamus is not releasing that CRH, then it doesn't know to tell the adrenal glands that it needs more cortisol. So that is where the tertiary issue comes into play. So make sure you guys write those down and understand those. So primary and secondary Addison's disease, we're talking about a low level of cortisol and aldosterone. But with tertiary, we're only talking about a low level of cortisol because the pituitary gland can still let the adrenal glands know that we need more aldosterone. All right, now before we start comparing the Addison's disease pathophysiology to the Cushing syndrome, let's first start talking about the signs and symptoms because they directly relate to the pathophysiology. We're going to explain it in a deeper manner there before we backtrack to the Cushing syndrome again. All right, so signs and symptoms of Addison's disease. So when we're talking about Addison's disease signs and symptoms, I want you guys to remember these big 4 points. It is hypotension, hypoglycemia, weight loss, and then bronze coloration. Make sure you guys write those down. We're going to explain each one of these. First, talking about hypotension. Why hypotension? Well, we got to think that the big highlight of this entire condition and the big complication is fluid deficit. Make sure you guys write that down. Why? Well, if we remember what aldosterone does, aldosterone responds and stimulates our kidneys to hold on to water and sodium. Without aldosterone there, when there's a low level like there is with Addison's disease, then there's no communication to hold on to water and sodium when we are low in that vascular space in our body. So we're just going to continue dumping more fluid out, so we're going to be left with a fluid deficit. When we have low fluid in our vascular space, what does that cause? It causes hypotension. So that is why we have hypotension with Addison's disease. Secondly, we have hypoglycemia. Why hypoglycemia? Well, if we remember, cortisol has all sorts of functions, but one of the big functions is glucose balance. Without cortisol, we're going to have an imbalance of glucose control in our vascular space. To be very specific, cortisol helps with gluconeogenesis, which is the new production of glucose coming from the liver, so that way we can balance the glucose in our vascular space if it's low. Secondly, glycogenolysis. So for the same reason, glycogenolysis helps make sure that the blood glucose stays stable in that vascular space. So what cortisol does, it helps stimulate that process from happening and making sure that we can break down glucose that's already there in our liver to go into the vascular space to balance it out. So make sure it doesn't get too low. So in summary, gluconeogenesis, cortisol helps stimulate that process from happening, so that way we can make new glucose into the vascular space from the liver. And then on the other end, glycogenolysis, if we have glycogen stored in that liver, we can break it down to make sure it gets into the vascular space to once again prevent hypoglycemia. Without cortisol, that process is not stimulated. Another thing that low cortisol levels do in our vascular space is increase the sensitivity to insulin, because insulin's counteractive partner is the cortisol. So when there's just insulin and a low level of cortisol, insulin's going to have a fun day of getting that glucose that's in our vascular space into the cells easier. So we have an increased sensitivity to insulin as well, so that once again will cause hypoglycemia. Lastly, if you guys remember, we're going to start talking about Cushing syndrome. One of those signs and symptoms is a very high appetite. Well, if we have a low cortisol, we're going to have a very low appetite. So there could also be a lower availability of carbohydrates to even transfer into the vascular space. That's why we have hypoglycemia. So that really speaks to why we have weight loss. So when we have low levels of glucose that can even be transferred into the body in stored form as glycogen, then we're going to have some weight loss because we're not absorbing those nutrients into our cells as much as we need to. So weight loss is another sign and symptom of Addison's disease. And then lastly, the thing we talked about with the 4 points, that last point is bronze coloration. Why? This is something that the NCLEX and the nursing exams kind of like to hint at. If you can identify that bronze coloration is related to Addison's disease. Without getting too deep into this concept, because you won't necessarily need to know it, but it is interesting. So when we have a decreased level of cortisol and aldosterone, it stimulates our pituitary gland to say, hey, we need to stimulate more ACTH to help make sure that these adrenal glands know they should be releasing cortisol and aldosterone. All right, well, when that overproduction happens, they're going to keep producing more ACTH. When that's not being utilized by the adrenal glands because they're having a primary attack here, they're not able to release it, well, that's also going to stimulate something called melanocyte stimulating hormone, other words, MSH. And what that does is it increases the production of melanin, which darkens the skin. So we might have some bronze coloration related to Addison's disease, especially if it's primary Addison's disease. So we gave you the big 4 points with Addison's disease. Just make sure you guys remember all the things that could be correlated with those big 4. So we talk about fluid deficit. What is most common? We talk about hypotension. Well, what comes with fluid deficit hypotension? Tachycardia. And of course, they may reflect your case on a hypoglycemia signs and symptoms, so make sure you guys know that. So increased anxiety, you got aggression, behavior changes, of course, decreased level of consciousness related to hypoglycemia, so make sure you guys relate those big 4 points to some other sub-item assessment findings. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. All right, now before we get any further on Addison's disease, let's go compare it to what Cushing's syndrome is. Let's first explain simply what is Cushing's syndrome. Cushing's syndrome is the opposite of Addison's disease. So Addison's disease was low cortisol and low aldosterone. Well, Cushing's disease is high cortisol. Now, aldosterone is not directly affected by Cushing's syndrome, but it kind of acts in the same way because we're going to get into that here pretty soon. So what happens if we have too much cortisol? We're going to have something called acromegaly, which is too much growth hormone, so an abnormal growth of bones, muscles, and so on. And then also inflammation once again. Now we talked about how Addison's disease was hypotension and hypoglycemia. Cushing syndrome, you can expect it. It's the exact opposite. It's hypertension and hyperglycemia. And of course, the big highlight of this entire condition, we talked about how Addison's disease is fluid deficit. Well, Cushing syndrome, once again, the exact opposite. It is fluid overload. So in summary, Cushing syndrome is the overproduction of cortisol, and what that causes is an increased production of growth hormone and inflammation. And just how we talked about how the lack of cortisol will cause hypotension and hypoglycemia, well, when you have too much of it, it's going to cause hypertension and hyperglycemia. But what about the fluid overload? So we talked about how we were going to get into that. So let's actually dive deep into understanding what Cushing syndrome does with the actual fluid balance of our body, because it is important to understand. So we talked about how Addison's disease is a low level of cortisol and aldosterone. Well, Cushing syndrome is just the high level of cortisol, not necessarily a high level of aldosterone. It can happen, but it would be more indirect if it was an occurrence with your patient. But it's important to know at high levels of cortisol, it can have a mineralocorticoid-like activity like aldosterone. So with high cortisol, it's actually telling our kidneys to, once again, hold on to sodium and water. So it's very similar as if they did have high aldosterone levels, but it's just important to know that it's not necessarily a direct relation to high aldosterone. It's just because high cortisol levels can mimic mineralocorticoid levels, just like high aldosterone. So what happens with that? We have fluid overload. We have hypertension because of the fluid overload. So we gave that example with Addison's disease, where we're dumping a bunch of fluid. They have hypotension because there's no fluid left in the vascular space. Well, it's the exact opposite now. Well, we have a retention. Our kidneys are being told, hold on to all the sodium, hold on to all the water. So we have a distended vascular system with a bunch of fluid, causing hypertension. And then we talked about how Addison's disease, once again, if there's not enough cortisol in that vascular space, there's no balance of glucose. Well, if we have too much cortisol, that gluconeogenesis is going, and that glycogenolysis is going. So it's going to be releasing more glucose in that vascular space. And it's also going to counteract insulin. So it's actually going to decrease insulin sensitivity versus with Addison's disease where it increased insulin sensitivity because the cortisol levels were low. So really guys, when you're writing your notes, just make sure that you have these opposites going on and you're relating it to the pathophysiology as we talked about. Now, there are some different concepts that the NCLEX and the nursing exam love to ask about related to Cushing syndrome. So I'm going to give you those big concepts. Then we're going to talk about the rest in relation to the patho we just discussed. The NCLEX and the nursing exams love to reflect on the moon face sign and symptom, hirsutism, which is hair growth, abnormal hair growth, especially in females that have maybe facial hair. And then we have the buffalo hump, which is the big hump on the upper neck there. We'll show a picture with that. And of course, they have thinning hair. So especially with women, these signs and symptoms are very obvious. So once again, moon face, hirsutism, buffalo hump, and thinning hair. You may ask, why are these signs and symptoms prevalent with Cushing syndrome? Well, once again, cortisol causes a lot of inflammation and of course fluid overload. So we have a lot of inflammation along with high fluid in our vascular space. So it's going to cause things such as a bloated face or a bloated everywhere. And especially when we have fluid overload, they're also at risk for peripheral edema. And the hirsutism, which is abnormal hair growth and abnormal spots, is related to the acromegaly, so the growth hormone stimulation related to the high cortisol levels. And then same thing with the thinning hair as well. And then once again, guys, make those sub-item signs and symptoms related to the other big pathophysiology concepts we talked about. Hyperglycemia, so what are the signs and symptoms of those? Hypertension, typically not a whole lot of signs and symptoms, but that's a sign and symptom in itself. But some other ones you can write down is these patients typically have skinny extremities and a bloated torso. They may have impotence as well. And with the skin findings, they may even have petechiae. All right, so let's move on to the next section. We have risk factors and complications. So let's first start with Addison's disease and we'll compare it with Cushing syndrome once again. So something I want you guys to write down with Addison's disease and Cushing syndrome, the primary risk factor is long-term corticosteroids. The most common patient you'll see with either of these diseases is someone who has been taking corticosteroids for a long time. But with Addison's disease, if there's an abrupt stoppage of those corticosteroids, that's where we have the lack of cortisol in the body because the adrenal glands have lost their natural production of the cortisol because they were getting the source from a medication. So the actual natural production of cortisol is lowered now. So when it's abruptly stopped, we're going to have low levels of cortisol and aldosterone, signifying Addison's disease. Now, of course, long periods of time when you're taking corticosteroids, you're at risk for developing Cushing syndrome because the cortisol levels are continuously high in your system. Now, we talked about with Addison's disease, there's secondary or tertiary causes as well. You may want to think about brain injury. So if there's a direct damage to the pituitary gland or the hypothalamus, you may have decreased levels of those hormones we talked about, CRH and ACTH, which would cause those low levels, such as in Addison's disease. And then you also got to think family history, infection, and trauma. All right, now what about the complications? Addison's disease, we want to think about adrenal crisis, which is profound hypotension and profound hypoglycemia. And because we have high levels of aldosterone, we're spilling lots of electrolytes, including potassium. When we have a potassium imbalance, we can think that they're at risk for arrhythmia, so that's another complication. Now, patients with Cushing syndrome are also at risk for adrenal crisis because they could potentially have it abruptly stopped. Secondly, though, the NCLEX loves to ask about these other concepts such as osteoporosis, hypertension, which could eventually over time cause heart failure because of the increased resistance on that ventricle, and not only the hypertension, but also the fluid overload, which stretches those ventricles out, causing increased stress on the heart and causing increased growth. And then lastly, diabetes insipidus is also possible with Cushing syndrome because high levels of cortisol can inhibit the release of antidiuretic hormone, which comes from the posterior lobe of the pituitary gland. If you guys haven't watched our video before, we have videos about diabetes insipidus versus SIADH. So make sure you guys go watch that. All right, now we're into the diagnostics of Addison's disease and Cushing syndrome. Once again, let's start with Addison's disease. The primary diagnostic test is an ACTH stimulation test. So with this ACTH stimulation test, we're given ACTH to see the response of the adrenal glands. If the response is deficient in producing cortisol and aldosterone, then we can likely diagnose them with Addison's disease. Now, of course, when you're doing electrolyte panels, you're most likely going to see those effects. You're likely going to see hyponatremia and hyperkalemia. And then once again, we talked about it, hypoglycemia will likely be seen in the lab values as well. Now, with Cushing syndrome, you could likely see hyperglycemia, hypernatremia, and then hypokalemia. You may also see a high white blood cell count because of the increased inflammation throughout the entire body. All right, now let's get into our last section, the management. So management of first Addison's disease, once again, what are the primary issues we have to deal with Addison's disease? Well, we have fluid deficit. That's the big issue. Then we also have hypoglycemia. So what could help fix those two issues right off the bat? It's dextrose IV fluids. Dextrose IV fluids is the general thing that you need to know about with your management of Addison's disease. Now, although dextrose IV fluids are recommended, it's actually typically recommended to avoid hypotonic solutions. It's important to note, please write this down, that we should avoid hypotonic solutions at first because it could initially drop the electrolytes even worse, so hyponatremia, and what that would do, it would worsen the dehydration that we already have. So it's important maybe fluids such as D5NS or D10NS instead of a hypotonic solution such as D5W. So overall, make sure you know that it's dextrose isotonic fluids and do not use dextrose hypotonic fluids such as a D5W. Now, the primary management to help with Addison's disease is, of course, lifelong corticosteroids. So they need corticosteroids to provide the cortisol to work in the body. And since we have low aldosterone levels as well, we're likely going to be giving them fludrocortisone, which helps increase the aldosterone levels. Now, specifically to the diet, we want to promote increased sodium, protein, and decrease the potassium intake. Now, specifically your nursing interventions, we of course want to look out for those complications at the bedside. So think arrhythmias, once again, adrenal crisis. So really frequently monitor their labs, their blood glucose, and their EKG rhythm. And of course, we want to do strict I's and O's. So we want to really make sure we know exactly what's coming in and out And then secondly, we want to make sure we do daily weights. Now, the management of Cushing syndrome is a little bit more simplified. We can gradually decrease or withdraw those corticosteroids that are causing the issue in the first place. So we have to, of course, monitor a lot of different aspects in the treatment plan, but overall, gradually decreasing those corticosteroids would help decrease the cortisol level. The diet for Cushing syndrome is also high protein, but this time also high potassium, and instead low sodium. Now, we talked about one of those big complications of Cushing syndrome is osteoporosis, which puts them at risk for fractures. Well, we want to make sure we look at that level as well. So we may be doing a bone density scan, and if it's low enough, then we would be giving them biphosphonates. Here are some common medications with the biphosphonates, and while we're on it, here are the medications that are commonly seen with the corticosteroids, so you can identify those for your nursing exam or the NCLEX. Now, if the Cushing syndrome is related to an increased production of ACTH, then we would give them pasireotide diaspartate. And once again, guys, the nursing interventions are pretty similar to the Addison's disease because we are talking the same problem. It's just the imbalance of cortisol. So we want to make sure we're doing strict I's and O's, daily weights, monitor that EKG because of the electrolyte imbalances that are possible, monitor for adrenal crisis, and then lastly, you must consider that these patients are at increased risk for fractures, so make sure we are being very careful with fall prevention. All right, guys, I hope this helped you understand what Addison's disease and Cushing syndrome is all about. I hope you guys were able to download our free pathophysiology concept map to take the notes. Thank you guys so much for watching, and we'll see you in the next video. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.